Hey guys, my name's Aaron with Ross Training Academy. I am a nationally registered paramedic. I've been doing this for just about 6 years now. Today we're just going to be talking about ACLS, which is just Advanced Cardiac Life Support. Before you guys watch this video and try to learn ACLS, make sure that your BLS care, your just basic CPR, is really good. Make sure that you remember everything about that. And if you don't, I have a refresher on this channel as well, so make sure you check out that video. So, just again, Advanced Cardiac Life Support. So, how is ACLS different than BLS? Well, ACLS is just an extension of BLS care. You can't have good ALS, great ALS, without amazing BLS. BLS before ALS or ACLS. This isn't really going to be a rhythm interpretation course. You should know already how to interpret cardiac rhythms, 4 leads and 12 leads. So just make sure you know that stuff before you start your ACLS. And then also now with ACLS, you're going to be performing synchronized cardioversions, defibrillations, cardiac pacing. You're going to be giving medications to help with the cardiac arrest, whereas in BLS you don't do anything like that. You just throw on the AED and we do what it says, right? So with ACLS, we just talked about a whole bunch of different kinds of shocks. What are the different kinds of shocks? How are we shocking people? So we're going to have synchronized cardioversion. This is just going to be a controlled, synchronized electrical impulse that will happen within the QRS complex on the R wave. So on your cardiac monitor, you're going to look for, just like a little triangle, or just like a little spike in the center of the QRS complex on the R wave, just to make sure you're synced up. And then you're going to synchronize cardiovert somebody, and you're going to put your cardiac monitor at 100 to 360 joules. And that's going to be how we're going to do our synchronized cardioversion. Also, synchronized cardioversion is going to be for tachycardias. Cardiac pacing is going to be for your bradycardic rhythms or your slow heartbeats. You're going to use a low dose millivolt electrical impulse for this person, and you're essentially just going to take over the pacemaker cells of the heart. It'll typically be the P wave that you're going to take over. You're going to take over the P wave, but you might also be taking over the QRS complex as well. The typical way to do this is you're going to set the heart rate up to about 70 to 80, or between that 60 to 100 normal heart rate or normal heart rate. And then we're going to put our millivolts up to at least that 70, 80. Whatever we set our heart rate at, we're probably just going to jump our millivolts to that heart rate number. And then what we're going to be looking for is a pacer spike followed by a QRS complex. So you want one pacer spike for every one QRS complex. If you don't see that, then we're just going to keep increasing our millivolts on our cardiac monitor until we see a pacer spike and a QRS complex right after. Now, once you see a pacer spike and a QRS complex following it, you want to make sure that you have mechanical capture. So we see on the monitor that we have electrical capture, pacer spike, QRS complex, but now we want to make sure we have mechanical capture. And all we're going to do is we're going to see how many heartbeats are on the monitor. So if we set it at 80 heartbeats, we're then going to feel for a pulse on our patient, and we're going to look for 80 heartbeats. So just make sure that stuff lines up. Once you have electrical and mechanical capture, you're just going to move up your millivolts, 5 to 10 millivolts in addition, just to make sure that you maintain capture for your patient. And then we have defibrillation. We defibrillate dead people. So defibrillate dead, they both start with D. That's a good way to remember it. It's just going to be a uncontrolled shock to the heart. There's no syncing, there's no pacing, nothing like that. We're just going to set our electrical impulse to about 200 to 360 joules. And then we're just going to shock this person, make sure everybody's clear, and we're going to hit that shock, defibrillate the heart, and then we're going to hop back on chest compressions. So with ACLS, we want to start thinking about the H's and T's now, and the H's and T's are just going to be reversible causes of cardiac arrest. For an adult, your H's are going to be hypovolemia, and we're going to treat that by stopping the fluid loss, however that may be, stop the bleeding. And then we're going to administer fluids. If they were bleeding, let's give them some blood maybe. Hypoxia will be the next one. So make sure you have a patent airway. Make sure you're ventilating this patient. Then hydrogen ion excess, or just acidosis. Make sure ventilations are adequate. Maybe consider giving some bicarb to this person. And then we're going to have hypo and hyperkalemia, sodium bicarb, calcium, magnesium, maybe even potassium for this person. And then we have hypo or hyperthermia, and we're just going to cool or warm this patient up. And then we have our T's. Our first T is going to be cardiac tamponade, and this is saying thoracotomy. That's just a misprint. You're really going to do like a needle tap or a pericardial stentesis, and you're just going to drain the fluid from the pericardial sac around the heart. Then we have toxins, which are just going to be drugs, overdoses. The treatment for that is just going to be dependent on what drug was used to cause that cardiac arrest event. And then we have tension pneumothorax. We're just going to needle decompress this person, get a chest tube, finger thoracotomy. And then we have pulmonary thrombosis. So give some anticoagulants and fibrinolytics. And then we have coronary thrombosis. This person's probably going to need a stent to be placed. And then think about your MONA or your FONA. And those are going to be your H's and T's. So now we're going to start talking about ACLS and cardiac arrest. Every cardiac arrest event, you're going to start with 2 minutes of continuous CPR. You're going to get IV or IO access. You're going to administer fluids, maybe with a pressure bag. Good quality BLS CPR. Get an airway, a definitive airway, so either a supraglottic airway or intubation. We want to monitor end-tidal CO2, so get that going. We're going to attach our AED and defibrillator. And then we're going to start thinking about defibrillating this person between 120 to 360 joules. If you already have the pads on and the person goes into pulseless VTAC or pulseless VFib, then we're just going to go ahead and defibrillate them. We already have the pads on. Just send the electricity. If you don't have the pads on yet, we're going to be doing our CPR until we get the pads on, finish your 2-minute cycle, and then we're going to defibrillate this person. There is some controversy on starting at 360 joules, so just learn your protocols, learn what your system uses, what your system does, and just go with that. Bring it up to your medical director or whoever your doctor is and see if things can change, see why they choose to do what they do. But that's essentially what we're going to be doing for this course. And then every dead person is just going to get 1 milligram IV or IO of 1 to 10,000 cardiac epinephrine. And you're going to give this every 3 to 5 minutes for the entire resuscitation attempt. Now again, there is some controversy over that. Some people might be maxed out at 3 doses of cardiac epinephrine. Learn your protocols. Some people might be maxed out at 3 doses of cardiac epinephrine per cardiac arrest event. So if you give your 3 doses, you can't give any more. But if you get ROSC and then the person goes into cardiac arrest again, then you can give 3 more doses. But just learn your protocols. And then for pulseless VTAC and pulseless VFib, we are going to administer 300 milligrams IV or IO of amiodarone. This is just going to be a really fast push through the IV or through the IO. And then we're going to repeat this at 150 milligrams in 3 to 5 minutes. You might also hear lidocaine instead of amiodarone, and the lidocaine dose is going to be 1.0 to 1.5 milligrams per kilogram IV or IO. And then we're going to half that dose in about 5 to 10 minutes and re-administer it for a max total of 3 milligrams per kilogram. And then we're just going to go ahead and consider our H's and T's. Now, let's look at pulseless VTAC and VFib. So, we're just going to be on SkillStat here. It's a free website. Everybody can check it out. But this right here is going to be what VTAC looks like. Monomorphic VTAC. And that's basically what you're going to be seeing. And then you might also see this here. This here is just going to be VFib. The ventricle's just kind of shaking. And that's just what that'll look like. So there will not be a pulse with either of these. But of course, always feel for a pulse every 2 minutes and before starting CPR. And remember, we only do chest compressions if there is no pulse and they are not breathing. Now let's talk about asystole or PEA. This is going to be a really easy one to remember. You're going to do your high quality BLS CPR, end tidal monitoring, get the AED and defibrillator pads on, get your IV, IO access, give some fluids, just saline, maybe through a pressure bag. We're just going to do our CPR with 2-minute rhythm checks. We're not going to do a whole lot else for this person. Of course, every dead person gets the basic same setup, essentially. But that's just what we're going to do for this person. Then the only medication we can give somebody, an asystole or PEA, is just going to be 1 milligram of cardiac epinephrine. And we're going to give this every 3 to 5 minutes for the entire resuscitation attempt. Now again, learn your protocols, learn what they say you can do, talk to your doctor, figure out what they want you to do. But that's it. You're going to consider your H's and T's. Now, let's go ahead and look at, if I can find it. So PEA is going to look like anything. PEA can look, probably not like that one, but PEA could look like this. This looks like sinus bradycardia to me. But if there's no pulse, then it's PEA. It might also look like this. If there is no pulse, it is PEA. And then it could even look like this, just that 3rd-degree heart block. This would still be PEA. So PEA, pulseless electrical activity, can look like any cardiac rhythm. So just go with that. And then we have asystole, which is just going to be that flat line. And give me a second because I am not seeing it on here. Alright, so I wasn't able to find asystole on that EKG sim or SkillStat. For whatever reason, I just wasn't seeing it. Maybe I'm tired. I have no idea. But asystole is just going to be that flat line. The heart rhythm is just going to be flat. If you see any little deviations in it, maybe kind of something like that. If you want to maybe try to call that fine VFib, maybe, then you can treat it like VFib, maybe more something like this. But yeah, no, asystole is just going to be a flat line. And that's what that'll look like. Alright, so congratulations. We got ROSC. Now, ROSC is just return of spontaneous circulation. This person now has a heartbeat. They probably will still be unconscious. They probably won't be breathing too good on their own. So we're still going to have to do some pretty good supportive care to make sure this person stays alive. We're still going to maintain their airway. We're still going to have end tidal monitoring, and we're going to optimize oxygenation and ventilation. This person is probably going to be hypotensive. If they are, keep giving some IV fluids, probably through a pressure bag. But now we're going to start thinking about a vasopressor. Epinephrine is kind of the preferred vasopressor now. The dose is going to be 0.1 to 0.5 micrograms per kilogram a minute. You might also see dopamine. Dopamine is going to be 2 to 20 micrograms per kilogram a minute. And then you might even see norepinephrine, which is going to be 0.1 to 0.5 micrograms per kilogram a minute. Learn your protocols for dosing. This is just like a general guideline for it, for all these doses. Epinephrine is the gold standard. It's going to increase the heart rate, and it's going to constrict the blood vessels pretty good. Norepinephrine is also kind of common. It's really just going to support the blood pressure, cause that vasoconstriction. It's not going to do a whole lot for the heart rate, at least not in these small doses here. As you start increasing those doses, maybe I kind of lost what I was saying, but as we start increasing that dose, you might start seeing some more cardiac, the heart rate, kind of jump up, but it's not going to be a whole lot. Epinephrine would be the gold standard for this. So yeah, when you get ROSC, we're going to go ahead and get a 12-lead EKG. Let's see what heart rhythm they're in. Let's see if there's any blocks going on. Let's see maybe why they went into cardiac arrest. And then we're going to start just actively cooling this patient. This is going to be more of a long-term thing. Actively cooling just means knocking down their temperature by about 2 degrees Fahrenheit, 2-3 degrees Fahrenheit. Throw some ice packs, in the armpits and the groin, just in those, where those really big blood vessels are, in those junctional sites. And just start cooling off their body a little bit. We're still going to consider the H's and T's, and we're going to get them to a hospital. Somebody with ROSC, when you get ROSC and you're on scene and in somebody's house, sit there for a minute, get all these things done, get the vasopressors going. You might even need 2 or 3 different types of vasopressors. If protocols allow, you might even have to do like a push dose epinephrine. But make sure that they're going to keep their heart rate and keep their heartbeat during transport. You don't want to lose that heartbeat while you're transporting, because CPR is not effective when we're transporting. That's why we don't load and go anymore. That's why we sit on scene and really try to stabilize these people, because we can do a lot. We can do everything ACLS wise, essentially, that could be done in a hospital by a doctor. Also with ROSC, if they're bradycardic, pace them. Try to pace them. Use the vasopressor and pace their heart rate. Try to increase that. Let's help them out the best we can. Now we're just going to talk about bradycardia with a pulse. Now we're going to start having to think, is this person hemodynamically unstable? They need to have that altered mental status and low blood pressure, right? That's when they're hemodynamically unstable. Somebody might be bradycardic with a systolic in the 90s, but if they're not altered at all, it's less concerning. We still may want to treat this person, but we're not going to treat them as aggressively. We're going to get an IV and an IO established, give some fluids, see if that helps, a little 250 fluid bolus, get a 12-lead EKG going, and then we're going to administer atropine, 1 milligram through an IV. We can repeat this in 3 to 5 minutes for a total dose of 3 milligrams. This atropine is not recommended for wide complex bradycardias, but it can work for all narrow QRS complex bradycardias. So give it a shot. Let's see. If the atropine isn't working, you can consider a vasopressor. Again, epinephrine, 2 to 10 micrograms a minute, because they're bradycardic. So we're just gonna try it. We're gonna up that dose compared to when we had ROSC. We're gonna do 2 to 10 micrograms a minute, and we're gonna just titrate to effect. Or we can use dopamine at 2 to 10 micrograms per kilogram a minute. If none of these things are working, Or if this person is unstable, they have altered mental status and they're hypotensive, we're just going to jump straight to pacing. We are going to consider sedating this person, maybe a little bit of Versed, just 2 milligrams maybe. But if they're unstable, we don't want to mess with their blood pressure a whole lot. So maybe we're just going to start pacing first and then worry about their pain and discomfort from the pacing a little bit later, right? We're not really going to use norepinephrine for this person because, again, norepinephrine doesn't really increase the heart rate. It just constricts blood vessels for the most part, right? So we're not really going to use it. And of course, consider your H's and T's. Now, let's talk about tachycardia with a pulse. Now, if this person is stable, so no altered mental status, no hypotension, let's get an IV and an IO, give a fluid bolus, make sure they're oxygenating well. If it's a narrow QRS complex, something like SVT, we're going to attempt some vagal maneuvers. And the way to do a vagal maneuver is, put some ice packs on their neck, tell them to bear down as if they need to poop. What I like to do is I like to give them an empty syringe and tell them to blow through it as if they're trying to push the plunger out the backside. And that stimulates that vagus response to hopefully lower that heart rate. If these things aren't working, or while we're trying the vagal maneuvers, I might just go ahead and start drawing up some adenosine. Adenosine, that dose is going to be 12 milligrams, and this is going to be a rapid push. So you want that IV to preferably be over on the left side, maybe even get a bicep IV or an EJ, just real close to the heart. And we're just going to slam this in, and we're going to follow it with a lot of saline. Adenosine has a very short half-life, so let's slam it in as fast as we can. Now, if the QRS complex is wide, so like VTAC or SVT with aberrancy, we can attempt the 12 milligrams of adenosine rapid push, or we're going to give amiodarone 150 milligrams over about 10 minutes, and this can be repeated. Sorry, the camera had cut out. We're going to give that amiodarone 150 milligrams over 10 minutes, repeat as needed, or we're just going to go ahead and synchronize cardiovert this person. Again, maybe sedate them a little bit, give them something for pain, but don't delay the synchronized cardioversion if this person needs it. And then if this person's in torsades, we're going to give 2 grams of magnesium, and that'll hopefully take them out of that torsades. If that doesn't work, we are going to try to synchronize cardiovert them. You probably won't be able to sync it. So unfortunately, we are just going to be defibrillating this person, most likely. And then we have AFib, so atrial fibrillation. We're not going to treat all AFib. We're only going to treat AFib RVR. And all that RVR means is rapid ventricular response. And when somebody's in AFib RVR, all that means is they have AFib with tachycardia. And tachycardia is anything that's over 100 beats a minute or over 100 QRS complexes a minute. So if somebody's in AFib RVR with a heart rate of about 110, we're probably not going to go crazy treating this person. We're going to try to remove them away from whatever's making them anxious, maybe give them a little fluid bolus, maybe give them some oxygen, just try to naturally calm them down. We can try vagal maneuvers, because why not? And then we have to start wondering, is this a new onset AFib, or does this person know about AFib, that they have AFib? If it's a new onset, and this person does not take a blood thinner, we want to kind of stay away from synchronized cardioverting this person, just because if we synchronize cardiovert them, we might throw blood clots from the heart through the rest of the body. So just use caution with that. But you're going to have to do what's best in that instance. It's going to be a judgment call on if you're going to cardiovert that person or not, but that's something to consider. What we can use is a calcium channel blocker, just a medication. Cardizem, deltiazem is what it's going to be called. Depending on where you work in your protocols, the dosing might be 0.25 to 0.35 milligrams per kilogram for a max dose of 20-25 milligrams. or you might just do 15 to 20 milligrams, and then I believe you can repeat that dose twice for a total of 2 times. But again, just learn your protocols, learn what your doctors want you guys to do. But that'll be AFib. So, real quick, let's go ahead and look at some of these tachycardias. So, let's go back to our skill stat. And we have the sinus tachycardia. To treat sinus tachycardia, get this person away from whatever stimulus is causing their heart rate to be fast. Whether it's a family member or stress, just get them away from it. Maybe give a fluid bolus. Maybe give them some oxygen. But we're not going to do a whole lot for this person. We can try a vagal maneuver just because. But yeah, that's essentially it. That's what sinus tachycardia will kind of look like. And then we have that SVT. You can't really figure out where the P wave is because it's kind of buried in the T wave and just makes this really big peak. Sorry. And that's just kind of what that'll look like. And then let's see. Here's that VTAC. We've already looked at VTAC. Now this person has a pulse, so that'll be different. Let's see. I guess that's all that we're gonna look at with that. We can go ahead. Let's look at AFib. So that's what AFib will look like. This is not AFib RVR here, but this is just kind of that chaotic look of what AFib will look like. That irregular heartbeat with the fibrillation waves, all in between the QRS complexes. Yeah, so if somebody has a tachycardia with a pulse and they are unstable, we kind of already talked about all these things a little bit, but IVIO, 250 bolus of fluid, consider some sedation because you're going to synchronize cardiovert this person. You can consider the 12 milligrams of adenosine. You can consider 150 milligrams of amiodarone through a 10-minute drip. If they're an SVT, you're just going to synchronize cardiovert them from about 100 to 360 joules. VTAC, 100 to 360 joules. AFib, 120 to 360 joules. Somewhere around there is what you're just going to do for this person. Learn your protocols, learn what they want you to do. Some protocols, you're just going to jump to that max, 360. Other protocols, you're going to start at about 200 and just step your way up. Pros and cons to each, but that's up to your medical director to decide. Let's go ahead and let's talk about acute coronary syndrome, or STEMIs, or NSTEMIs, or even OMIs, which is a new thing. An OMI, OMI, is just an occlusion MI. If the person is hypoxic, meaning their SpO2 level is below 94% of room air, we're going to give them oxygen just to get them above or at that 94%. We're not going to oxygenate this person. We're going to get IV and IO access, maybe even a couple large bore IVs for everybody, right? We're going to administer 324 milligrams of chewable baby aspirin. If this person is on a blood thinner, that's okay. They can still have this chewable baby aspirin. If somebody's already taken aspirin, but they've only taken a couple pills, they haven't reached that 324 milligram dose, we're just going to go ahead and finish off that dose. So if they've taken 2 pills for 180 milligrams, 182 or whatever that number is, we're just going to give them 2 more pills to chew up just to reach that 324 milligram dose. And aspirin is the only proven medication that we have on an ambulance that is going to help their occlusion MI, or their STEMI, or their ACLS, whatever you want to call it. And then we have nitro. So 0.4 milligrams of nitro every 5 minutes for a total dose of 3. If it's not contraindicated, meaning that they haven't taken any erectile dysfunction medications within the last 24 hours, or their blood pressure allows for it, so they don't have a systolic blood pressure at or below about 100 systolic. If they're sitting at about 110, really consider if they need the nitro. Make sure you have an IV before you give somebody nitro, no matter what their blood pressure is. And then we're going to give, something for pain. We can do some morphine, 2 to 4 milligrams, titrate to effect, or we're going to give just a small dose of fentanyl, 25 to 50 micrograms, titrate to effect, right? And that's where that like Mona or Fona comes from. Mona is just going to be morphine, oxygen, nitro, aspirin. Fona is just going to be fentanyl, oxygen, nitro, aspirin. And then with somebody with a heart attack, who's having a heart attack, ST elevation, we want to maintain the lowest heart rate and blood pressure possible for this patient without them showing signs of shock and hypoperfusion. Realistically, you want the heart rate to be at or above 60-ish, and then the blood pressure systolic to be at or above 90-ish systolic. But as long as they aren't altered, we're doing good. Now, let's jump on over to hypotension. So of course, ensure adequate ventilation and oxygenation, get your IVs going, IOs going, give a fluid bolus, get the systolic blood pressure to at least that 90 systolic. You can consider a vasopressor, epinephrine or norepinephrine, whichever you see fit for this given scenario, 0.1 to 0.5 micrograms per kilogram a minute, or dopamine, which has kind of fallen out of favor, but dopamine 2 to 20 micrograms per kilogram a minute. If they're hypotensive, get a 12 lead and then use the appropriate tachycardic or bradycardic algorithms if it's indicated, and then consider your H's and T's. Let's talk about some acute pulmonary edema. So, acute pulmonary edema, somebody has CHF. That's what we're assuming in this case. Congestive heart failure. Right is tight, left is wet. Left-sided heart failure tends to have, that crackles, that lung sound, that rails in the lungs. Right is tight, that just means that fluid backs up towards gravity. And so that's typically down in the legs, lower extremity edema is kind of what you'll start seeing in that person. To treat them, the SpO2 level should be at about 94%. We're going to make sure that it is. We're going to ventilate them. We're going to oxygenate them. We're going to use CPAP if it's indicated and not contraindicated. So if the person's altered, probably not going to use CPAP. If their blood pressure is below 90 to 100 systolic, depending on your protocols, we're probably not going to use CPAP. We might just have to go ahead and start bagging this person using your bag valve mask, your BVM, your ambu bag, and just ventilate this person. We're going to get an IV or an IO established. If their blood pressure allows, we're going to give them 0.4 milligrams of nitro up to that 3 total doses every 5 minutes. Again, just as long as their blood pressure remains above that 90 to 100 systolic. And then we can start considering furosemide or Lasix. This will be 0.5 to 1 milligram per kilogram, so about 20 to 50 milligrams-ish, depending on your protocols, is what the dose is going to be. And then some pain management, if it's needed. Consider half dosing whatever you were going to give, just so that the patient maintains their blood pressure. And then consider all your other H's and T's, right? All right, so now we're going to talk about hypothermia. Somebody's cold. Get them out of that cold environment, warm them up, oxygenate them, ventilate them. If the patient has a pulse and their body temperature is above 32 degrees Celsius, use external rewarming. So it just means put blankets on them. Maybe that Mylar blanket, that like tinfoil looking blanket. Throw some hot packs under there. Warm this person up. We're not going to sit there and rub their hands together. We might start, breaking the cells that are frozen in their fingers and their feet. You're not going to shake them too much, jostle them around or anything. We're going to consider internal warming with warm IV fluids. If you live in a cold environment, most ambulances have like IV fluid warmers, and you'll just give that to somebody. If their temperature is below that 32 degrees Celsius, we're going to do all that same stuff. We're just going to warm them up. But now we're going to have to use internal rewarming with that IV fluid. Now, if the person does not have a pulse, right, they're dead, right? Who would have thought? But if they're in VFib or VTAC, we're going to defibrillate them about that 120 to 200 joules, 120, 200, 360, you know, whatever your protocols say. And then we're just going to begin CPR. We're going to just do our CPR. If their temperature is above 32 degrees Celsius, we're going to go ahead and just use the normal CPR algorithms. Of course, try to warm this person up still. But we're just going to do our normal algorithm, just at prolonged intervals, as far as the medications go. So instead of epinephrine every 3 to 5 minutes, now it's going to be every 6 to 10 minutes. Just kind of double whatever the interval time. If their temperature is below 32 degrees Celsius, we're just going to do BLS basic CPR. No medications, no defibrillation. Get this person warm. They are not dead until they are warm and dead. So we're just going to warm them up, get them in a hospital where they're going to keep warming them up. And that's it, guys. If there's any questions or comments, concerns, anything you got, throw them down in the comments. I'll get back to you as soon as I can. That's it for this lecture. Of course, always follow your protocols. Learn what your medical directors and your doctors want you guys to do. This video here does not replace medical training. So make sure you're medically trained before you start doing anything like this, right? You're not just going to go out there and just start. So, yeah, that's it for this video. Thanks for watching, guys. See ya.